Hi, everybody. So my name is Evan Foster, and I'm a Master of Public Health student at the University of Illinois at Springfield. And so today I'm going to be presenting a paper I actually just wrote on some of the knowledge gaps in end-of-life care for patients suffering from chronic lung disease. So just to start out, palliative care, as I'm sure most of you know, is essential for supporting individuals suffering from chronic disease. Palliative care is a lot of times referred to as comfort care, end-of-life care. The purpose is generally to make patients as comfortable as possible. Chronic lung disease is a painful, frightening, and often debilitating set of circumstances for patients and caregivers. Anybody who suffers from it, it can be extremely painful to even breathe. Being able to catch a breath can be very difficult, and that's obviously for anybody that's a very terrifying situation to be in. Chronic lung disease is one of the 5 worst health outcomes in terms of morbidity and mortality, especially in developed countries. So we all know that heart disease is up there at the top. Obesity is a hugely concerning factor as well, but chronic lung disease is up there as well. So there's a lot of things that fall into chronic lung disease, COPD, emphysema, and several others, but it's definitely a very burdensome set of illnesses that impacts developed nations. So gaps in the literature include better diagnostics, inequities in access to care, rehabilitation, palliative care, technological interventions, ethics, holistic approaches to care, microbial interventions, weight loss for chronic lung disease patients with comorbid obesity, and others. Okay, so the purpose of the research question here is, 1, to identify shortcomings in current palliative care treatments, especially in particular for patients with chronic lung disease and their caregivers. So there are a lot of shortcomings. There's a lot of information that we just ultimately don't know because the research hasn't been done and it just hasn't been a focus. A lot of the focus when it comes to any chronic disease is how do we treat it? How do we extend the life of patients that are suffering from it? How do we make it as manageable as possible? Palliative care, on the other hand, these patients are at the end of their lives. They're at the last stages of disease. There's very little, if any, possibility of any real life after the disease progresses. So with these patients, we also have to look at the ethical aspect of how much should society contribute to patients who are already in at the dying stage of a disease. It's a very important ethical question and something that definitely needs to be considered moving forward. So another thing to consider is there is no current holistic framework for palliative care for chronic lung disease patients. When I'm talking about a holistic framework, I'm talking about a framework that considers caregivers and patients, considers the things that both of them want and need out of palliative care treatment, considers those expectations, considers quality of life from all different viewpoints, not just the viewpoint of, okay, can they eat, do things for themselves, make their own decisions, but truly looking at, are they coughing on a regular basis? Is it painful? What do the patients actually want? Do they want to continue living? Do they want to extend that life? So there's a lot of factors that we need to understand, and it needs to be on a large scale, not just looking at, of course we can ask individuals, but in order to develop plans and frameworks and additional studies and actually make improvements, we need to understand at a base level what patients want, what caregivers want, and what's ethical for us to do from a public health standpoint. We also need to understand what covariates impact both good and bad palliative care experiences. We need to look at, does location play a factor, socioeconomic status, those social determinants of health, and whether those things are impacting palliative care and the perceptions that caregivers and patients have of the palliative care treatments they're getting. we need to develop research opportunities by looking at both quantitative and qualitative data. And in this presentation, I'm actually going to present a multi-center, multi-year cohort approach that actually has ongoing enrollment due to the fact that obviously with end-of-life care, we have patients who are not going to be around very long and can't participate for an extended period of time in the same study. So as such, we need to continually recruit additional patients to the study, same with caregivers. So my proposal is a 10-year multi-center cohort with continuous enrollment. The first thing that anybody thinks of when they hear a multi-center cohort is the fact that it's going to be expensive. So for the purposes of this study, we're going to act like money doesn't matter. Obviously it does, but it's just to give you an idea of what can be done, why it would be beneficial, some of the strengths and weaknesses of such a study, and then what opportunities are there after the fact. So this would be a national study with 5 regional divisions. So as such, we take the country, divide it up into 5 parts, metropolitan study centers located in each. Laboratory contracts would be needed for any routine lab testing and reporting that would be done. It's another expensive aspect of the project. Each center would have their own grant specialist, their own grant writers in order to secure grants for those locations. It's expensive to hire grant writers, especially ones who are going to be looking at such a large area. However, it does provide the opportunity to get more grant money than would normally be available. So the methodology itself, we would have monthly questionnaires addressing 5 key areas: symptoms, discomfort, mental health, caregivers, and length of life. Terminal chronic lung disease patients and their caregivers are encouraged to participate. There aren't going to be a lot of exclusions. The reason behind that is we want as many people involved as possible, as many opinions, and as much data as possible. So we don't want to exclude anybody that we don't have to. One exclusion criteria we do have, however, would be anybody who can't consent themselves. Patients need to be able to consent themselves because we need to be able to get the most accurate, tangible, realistic information possible from these patients. If they can't give consent, chances are we're not going to get the information that we need. Okay, so my preference would be to not offer any financial incentive. Financial incentives tend to carry the risk that people are going to participate just for the incentive itself, which will bias the results. I don't want to do that. Now, any travel, lodging, or food expenses would be reimbursed, but no financial incentive upfront. And then data analysis would be performed on a rolling basis every month. That way we can identify trends and adjust study parameters. So this is another area where anybody who's done studies in the past understands that having monthly data analysis is expensive. You have people working, they have to do payroll, you have software, you have all of the resources that go into data analysis. It gets expensive very quickly. This is a very expensive project. There are a lot of considerations and a lot of things that would need to be reduced in order for it to be realistic. But this gives you an idea of something that could be done, especially with the backing of major patient care associations, stuff like that, they'll be able to help with the funding. So in terms of evaluation, internal evaluations are going to be done on a regular basis, preferably monthly. Again, expense-wise, it's not realistic. Quarterly would probably be a better bet, but this would allow us to adjust the study as necessary and add information to the questionnaires as it comes up. So the study would be evolving on a regular basis because we want to get as much qualitative data as possible too. We want to get those opinions, those experiences, and understand what would make palliative care better for both patients and caregivers. As such, we want to be able to adjust the study and get more information on things that come up as we're going, instead of just going through this entire process and then having to create new studies at the end. So again, added expense, added difficulty, lots of complexity. Data analysis is going to be extremely complex. You're going to need, obviously, regression analysis. You're going to need multivariate analyses as well. You're going to need several different ways of determining association strength. You're also going to need confidence intervals for everything. It's a lot of data work, a lot of software work. You will need somebody, well, a lot of people who can participate in doing that data analysis itself. So part of the evaluation process is looking at, is the study effectively determining what we want it to? So we're going to be looking at population characteristics associated with positive and negative end-of-life experiences most valued by patients and caregivers, and the associations with covariates, and then improvements sought by patients and caregivers, and then also, again, associating those with population characteristics. Annually, I'd like to see third-party evaluations being done, because that's going to look at effectiveness, confidentiality, sustainability, and actual progress. And then also third-party evaluations would be able to provide feedback and recommend changes for the study. These are my references. It was a very, very brief overview of the topic, but hopefully it gets everybody thinking, and feel free to reach out with any questions. Thank you.